So hi everybody. Today's session is updates in immunotherapy. Cancer immunotherapy harnesses the power of the immune system to recognize and kill cancer cells. Over the past decade, in a variety of cancer immunotherapy approaches have been evaluated in a number of cancer types. These include monoclonal antibodies, cancer vaccines, and adaptive cell therapies. While a number of these approaches have demonstrated promising efficacy, there has also unfortunately been a number of failures. This talk will provide the overview of cancer immunotherapy and will highlight how these treatments play an evolving role in treatment of early and late-stage cervical cancer. Our speaker today is Dr. Dmitriy Zamarin, who is a professor of oncology and section head of gynecologic medical oncology at Mount Sinai, where he takes care of women with gynecologic cancers, including cervical, endometrial, and ovarian cancers. He completed residency in internal medicine at the Mount Sinai Hospital and fellowship in hematology oncology at Memorial Sloan Kettering Cancer Center. He spent a decade as faculty and translational research director in gynecologic medical oncology at the Memorial Sloan Kettering Cancer Center before transitioning to his current role in September 2023. Dr. Zamarin has served as a principal investigator on multiple clinical trials exploring novel immunotherapy treatments in gynecologic cancers. In the laboratory, his research is focused on understanding of the mechanisms by which gynecologic cancers are recognized by the immune system and, uh, and on the identification of biomarkers predictive of response and resistance to immunotherapy. Dr. Zamarin, we are so thrilled to have you. Thank you so much for spending the time with us today.
Great, and thank you so much, Jillian, for the introduction and for the invitation. And of course, thank you for running this this organization. I think it's actually quite unique to have the ability of the patients to interact with each other and with the healthcare providers, and so this is certainly very nice. So I hope you will find this presentation at least somewhat useful. I'm going to try not to keep it very technical because I know there are a lot of sort of questions about what exactly immunotherapy is, but I will apologize in advance that at some points we may get somewhat technical. So please ask me any questions. Okay, good. So minimize some things here. So again, I will go through the slide deck, and again, just because this is Cervical Cancer Awareness Month, we will predominantly stick to the cervical cancer, which I'll hopefully be able to provide you with some of the recent updates that we have had in treatment for these cancers. And I usually, my research interest is focused on cancer immunology and immunotherapy, and I always like to start with highlighting some prominent figures that sort of brought us where we are. And here I'm putting up the little statue of Edward Jenner. So Edward Jenner was a physician that was practicing in 1700s, who first noticed that women who were exposed to cows, so those were the milkmaids, were the ones that would never get infected or die from smallpox. And this led to identification of a similar virus to smallpox that he was able to use to essentially vaccinate the women against the smallpox. And then essentially he's now considered to be the father of immunotherapy in general. And of course, his the technique that he has developed has led to complete eradication of smallpox, and hopefully will also teach us on how to use these kinds of tools to bring a better control to cancer treatments as well. So here are my disclosures. So again, we're keeping this talk predominantly focused on cervical cancer. So just give you the general overview of how common is cervical cancer. So globally, unfortunately, it is a very common disease. This is a map of this is from 4 years ago, but it's not. It hasn't unfortunately changed since then. Of how frequent we get a diagnosis of cervical cancer around the world. And fortunately, in the United States, this has become a rare cancer, but around the world, particularly in Africa, South America, and some parts of the Southeast Asia, the disease is still quite common. And many of you may know that the predominant factor that causes this disease is infection with the human papilloma viruses. So this is a primary cause of cervical cancer in the majority of women. And there are many different types of these viruses. Not all of them are the ones that can cause cancer, but there are some that are more likely to be associated with cancer. Essentially, these viruses infect normal cells in the cervix, and some of these viral genes get incorporated into the human genome. And these genes that are normally designed to propagate the virus or allow the virus to replicate, essentially also drive the division of these cells. And after our acquisition of a number of mutations, these cells become cancerous. So as you can imagine, if we can protect a patient from the virus infection, we can effectively prevent the infection and hopefully prevent the cancer. And we do now know that since introduction of anti-HPV vaccines in 2006, there have been a number of studies that demonstrated that the vaccination against HPV is actually quite effective in preventing the infection with the virus, and thus could potentially prevent over 90% of all of the HPV-associated cancers. And these are not just cervical cancers. HPV can cause disease in a number of other organs, including most commonly now head and neck cancers as well. So if we could potentially prevent HPV infection, we could globally prevent over 500,000 cancers in women and over 60,000 cancers in men annually. And it could also prevent potentially over 300,000 deaths globally annually. So vaccination with the goal of eradicating cervical cancer or HPV can certainly be a very powerful tool for cancer prevention. But we're not, and I just want to highlight that fortunately, again, the cervical cancer incidence is decreasing. And this we can all credit to effective screening strategies. This was initially introduced back in the 1960s, 1970s with the Pap smears, which was designed to sort of detect these early transformed cells in the cervix, and later on in the early 2000s with the introduction of the HPV vaccines. So it used to be a very common, this is just the curve for the United States, it used to be a fairly common disease, and again, over the past 30 to 40 years, the disease incidence has significantly decreased, but although over the past decade, it has remained relatively stable. So here's the basics of staging and the treatment of cervical cancer summarized in one slide. So by staging, we essentially always refer to where the cancer is located. So the earliest stages are usually for any cancer, whether this is cervical or any cancer. So for the earliest stages is the cancer that's confined just to the organ of where the cancer starts. And then as the cancer starts to grow and spread to other places, the stage increases. So for cervical cancer, if you have a very small cancer that's just confined to the cervix, it is considered to be stage 1. Once it starts getting bigger or growing out of the cervix, it's we call it a stage 2. If it goes to local lymph nodes or starts invading other structures in the vicinity, it is considered to be stage 3. And once it spreads to other organs, whether this is in the abdomen or even beyond the abdomen, that's considered to be stage 4. And depending on the stage of the cancer, we use different treatments. So for the earliest stage disease, we use surgery. For the stages 2 and 3, where the surgeon is unlikely to remove the entire cancer, we employ chemotherapy in combination with radiation. And of course, for cancer that has already spread or has come back, we don't use any surgery or radiation. Rather, we just use systemic chemotherapy with incorporation of some of the newer drugs called PD-1 inhibitors. And I'll talk about that a little bit later. And naturally, of course, that the earlier the stage, the lower the risk of the cancer coming back. And I have highlighted this below that, the later we detect the disease, the higher is the likelihood that the cancer may come back even after completion of our most effective therapies that we have. So this certainly highlights that new therapies are needed to change these recurrence rates, because they still, for some, even for some of these earlier cancers, while they are quite low, they're not 0%. So we could certainly do better. And as I mentioned, just the chemotherapy or chemotherapy in combination with radiation, unfortunately, have not been sufficient to cure all of the patients. So novel therapies are certainly needed. So with this, I want to introduce to you the whole concept of cancer immunology and immunotherapy. And it comes from the recognition that cancers are not only composed of cancer cells. So this is a diagram that can sort of highlight of what the cancer may look like under the microscope. This is not an actual picture of a cancer, but rather just a drawing. But you can see that cancers are filled with cancer cells. Those are those angry-looking purple cells in here. But there are a lot of other sort of cells and components that we can identify in the cancers. Many, we can see the blood vessels, we can see all sorts of connective tissue in there. And, a very prominent type of cell that also infiltrates these cancers is known as an immune cell. So this is part of your immune system. And there are many different types of immune cells out there. Some of them are called T cells, some of them are called B cells, and other kinds of cells as well. And the balance between these cells essentially determines whether the cancer will grow or not, because some of these cells are recruited to try to fight the cancer. But then there are other immune cells that have a pro-cancer role. Essentially, cancer cells recruit them to cause immunosuppression and prevent these good type of immune cells, like these cytotoxic T lymphocytes, from functioning appropriately. And of course, when the immune system fails to recognize and kill the cancer cells, this is when the cancers are able to grow to large size and metastasize to other places. So this is, again, a basic sort of a diagram highlighting what type of immune cells we have. These are the basic components of our immune system that's developed itself to fight both bacterial and viral infections, but also to fight cancers. And this is broadly subdivided in what we call innate immunity and adaptive immunity. So the reason we call this innate immunity is that these are sort of the cells that only recognize specific patterns that one may have in, for example, in viruses and bacteria. So these cells are very rapidly to respond to infection or any other kind of stimulus. And some of these cells are highlighted here, like neutrophils, macrophages, dendritic cells. And this type of immune system doesn't learn. So essentially, it is just sort of a very basic type of an immune response, a very rapid response to limit any an infection or other noxious stimuli. But you also have this adaptive immunity, which is slower to respond. But this is the type of immune system that once it responds, it can develop memory and then protect you further from a future infection or hopefully cancer as well. And this is the type of immunity that we try to harness whenever we vaccinate the patient against, let's say, a virus like influenza or any other virus. This is where we may give a patient an antigen. They have their B cells and T cells learn to recognize that antigen so that in the future, when the patient is challenged with an actual virus infection, they will be rapidly able to clear those viruses or bacteria. And again, these types of cells, like T cells and B cells, can also be effective in working against cancer. So then how does the immune system recognize tumor as non-self? So of course, we know that viruses and bacteria look very different from human cells. So the immune system can recognize them as foreign, but for the cancer cells, they're still quite similar. Well, it turns out that cancer cells do often make a variety of different proteins, or sometimes these proteins are different because they have mutations as a result of the cancer development, or the proteins are not normally expressed in normal cells, but then become upregulated in the cancer cells. And these are sort of the targets that the immune system sees as the non-self. So this is basically a diagram of what actually happens in this process of immune recognition. So the tumor cells, as they develop, they undergo a process known as lysing or lysis or dying. And as the tumors die, they release those proteins, and we call them antigens. These proteins then get taken up by a specialized type of an immune cell called antigen-presenting cell. And this immune cell chops up these proteins into little pieces of proteins, which we call peptides, and these get presented to T cells. And the T cells that specifically know how to recognize these different types of antigens then become activated and then migrate to the tumor site, where they're able to mediate lysis or killing of the tumor cells. So this process is essentially, that's at the center of how our immune system recognizes and kills the cancers. Of course, if this always worked, we would never get the cancer. So obviously, the process is broken in some steps, and the tumors evolve different mechanisms to escape from this immune response. And there are multiple mechanisms that may be at play, and this is actually what's used for us to develop different immunotherapies or drugs that are targeting these mechanisms. So, for example, tumor vaccines, essentially, as I mentioned, tumor vaccines are various types of strategies where we take these proteins or antigens and give them to the patients that have cancer. And the goal of these tumor vaccines is essentially to expand these T cells that may recognize these vaccines, so that they can go to the site of the tumors and mediate the killing of the cancer cells. We can also have a variety of other molecules we can add aside from the vaccines that work on activation of these antigen presenting cells or stimulation of cancer cell lysis. Again, this is to kind of to stimulate the immune system to also present these antigens and activate the T cells. We can try to deplete some of these immunosuppressive cells or the bad cells in the tumors. These essentially work by by inhibiting or blocking the immune response. So if we remove these cells from the tumors, the goal is to hopefully make the T cells work better. We can bypass this entire process and essentially grow out the T cells outside of the patient's body, the T cells that would be specific for the cancer, and then infuse large quantities of them into the patient. So then these T cells could hopefully go to the site of the tumor and kill the cancer cells. There are other small molecules called cytokines that we can use to stimulate the immune response. Some strategies actually use viruses. Viruses can directly and can infect and kill cancer cells, but also can produce a variety of molecules to activate the immune response. And this is the last sort of type of immunotherapy called immune checkpoint blockade or immune checkpoint inhibitors. And these are various monoclonal antibodies or biologics that target a number of molecules that are expressed on the surface of T cells and tumor cells and other cells that block these T cells from working. And to date, this has actually been the most successful strategy, and which has resulted in a number of drug approvals and across a number of cancer sites. But of course, you can see that this quickly becomes quite complicated because we have many different strategies to activate different components of the immune system. But as you can imagine, many of these might not work by themselves, but perhaps work in combination with each other. And a number of clinical trials is essentially working on identifying the most appropriate strategies that can be used in combination. So I want to briefly go over this immune checkpoint blockade because these are the drugs that we are currently using in clinic. So again, whenever you have these T cells become activated by these antigen presenting cells that essentially teach the T cells how to recognize these cancer antigens, these T cells that are activated, then they go to the site of the tumor and they start killing these cancer cells. And this process works to a certain extent until these T cells become what we call exhausted or dysfunctional. So they're still able to recognize cancer cells, but they just no longer produce these molecules that mediate the cancer cell killing, and the cancer cells stay alive. And that's just a normal mechanism that the body uses to prevent too much inflammation from happening. But unfortunately, cancers use these mechanisms to protect themselves. And one of the molecules that gets sort of expressed on the surface of these T cells is called PD-1. So identification of these molecules, like I said, I mentioned PD-1 here, but here's another one called CTLA-4, led to development of the drugs that can block these molecules. So again, these are negative regulators of the T cells working. So it's if a T cell is a car, then this is both CTLA-4 and PD-1 is a brake. So what these drugs, the immune checkpoint inhibitors do, they essentially block the brakes on the T cell, and that of course allows the car to continue rolling and working. So when we block CTLA-4 or we block the PD-1, the T cells don't undergo this process of exhaustion, so they continue to work and continue to kill cancer cells. And this type of therapy can be quite effective in a number of cancer types. This is in cervical cancer. This was a clinical trial where a PD-1 inhibitor, pembrolizumab, also known as Keytruda, was used in combination with chemotherapy in patients with cervical cancer that has come back. So whenever we look at efficacy of these drugs, we essentially look at what we call these survival curves, and this is basically it's looking at the percentage of patients and over the period of months that may have that continued to receive treatment or had to come off the therapy because the cancer grew. So you can see where the patients that just received chemotherapy alone in combination with placebo, that's the bottom curve. Patients who received chemotherapy in combination with pembrolizumab, that's the upper curve. And you can see that in these patient population, addition of immunotherapy has really sort of reduced the risk of the cancer growing over a period of time. It's not perfect. So you can see that still in the majority of the patients, eventually they do develop resistance to these drugs. But this was a first demonstration that that combination even of a standard chemotherapy with the drugs like pembrolizumab can improve outcomes for these patients. I also want to highlight that you can see that as the time goes along, there are fewer and fewer patients that continue to progress on these treatments. And this just highlights that if this treatment works, it can work for a very long time. And for the first time since sort of the invention of chemotherapy, we're actually starting seeing the patients that don't just have this long control of the cancer, but can actually be cured of their metastatic disease. So this, of course, made us ask a question of whether we have to wait until the patient's cancer comes back, or whether we can now start using these drugs earlier on. So sort of when the patients are first diagnosed with cervical cancer, can we use immunotherapy to combine it with with the radiation in that case? So that kind of a clinical trial was done and completed last year. So essentially, as I mentioned, again, patients with early stage cancer or like a stage 3 disease normally undergo just radiation in combination with chemotherapy, but here they received radiation, chemotherapy, and pembrolizumab. And again, you can see that the addition of pembrolizumab increased the likelihood that the patient's cancer would not come back. And there was and this is at 2 years. There was approximately a 10% improvement or increase in the number of patients whose cancer has not come back. This is not great. Obviously, we want this curve to be all the way up. We want all of the patients to be cured of the cervical cancer up front. But this is certainly a first step going forward. So on the basis of these findings, now for the earlier stage cancers, cervical cancers, FDA approved the addition of the pembrolizumab drug for therapy of the patients in an earlier setting. But as we do these kinds of studies, we also start asking a lot of questions of, well, is radiation the appropriate type of a combination partner for the immunotherapy? Because we know radiation is good because it kills cancer cells. It can potentially kill cancer cells, not just in this is a diagram of a cervix where you have the cancer here. So the radiation might not just kill cancer cells here, but radiation may also kill cancer cells that could be around the cervix because the radiation fields can be quite broad. But there are also negative effects of the radiation because, as you can imagine, we're not just killing cancer cells, we're killing the immune cells as well. So when we give these immunotherapy drugs like anti-PD-1, we're activating these T cells. Hopefully they're going to go to the site of the cancer and start killing the cancers, but we're immediately killing them with radiation. So this might not be necessarily the right approach. I mean, certainly, like I said, it helps maybe about 10% of the patients. Well, we could probably do better. So this is so we, for example, asked the question of whether we can still use this combination approach, but sequence immunotherapy and radiation differently. And so we did this small clinical trial with immunotherapy and radiation, where instead of doing the radiation and immunotherapy at the same time, we performed this sort of a randomized study where we started immunotherapy earlier. So with the goal of perhaps inducing an immune response to the cancer in the patients, which would become systemic, and then we treat them with the radiation. And we compared it to the patients who received just the standard radiation with immunotherapy. And this was a very small study, but even with that small study, we saw some promising outcomes that when we treated these patients starting with the immunotherapy, they did in general better. And this was a very high risk patient population, but nevertheless, close to 80% of them at 2 years did not have cancer come back. And if we, when we do these kinds of studies, we don't just look at how well does the patient control the cancer. We also take the biopsies to see whether there's evidence of immune response in these cancers. And we can look at those under the microscope. So here, these sort of cancer cells are shown here in green, and you have all sorts of immune cells in red and yellow. And we see how do these change from before radiation to afterwards. And we can see that, like this is a patient, for example, that's had obviously lots of cancer cells and immune cells in the beginning. And then after therapy, most of the cancer cells are gone. And this is just after 3 weeks on therapy. But we also still have patients that had a lot of cancer with very minimal number of immune cells in the cancer. And these patients, unfortunately, did not have such a good response. So understanding why certain patients do respond versus other patients do not respond to treatments is one of our primary research interests, because if we can identify the mechanisms for why these patients do or do not respond, we can develop better treatments for that. as well. But on the basis of our study, we're now developing a larger clinical trial that will compare earlier immunotherapy, or in this case, actually immunotherapy with chemotherapy before starting the chemoradiation. And we hope that the now addition of the immunotherapy upfront can help a larger number of patients with newly diagnosed cervical cancer. But but what do we do for the patients that have recurrent disease? So as I mentioned, right now, this is the standard of care that we have. So patients who are newly diagnosed with cervical cancer that has come back will receive chemotherapy in combination with a drug like pembrolizumab or Keytruda. If this therapy stops working, there are other now more novel lines of therapy that we have as well. And with that, I want to introduce another novel class of drugs, which is sort of an in-between immunotherapy and chemotherapy drug, and these are known as antibody drug conjugates, or ADCs. And essentially, these drugs are biologics. So we have an antibody, which is kind of an engineered type of a protein that specifically targets a molecule on the surface of a cancer cell. So many cancers may express the same type of molecules, which we can block with these antibodies. But besides just blocking these molecules, we can connect the antibody to a drug, in this case, chemotherapy drug. So essentially, as you can imagine, if we infuse this type of a drug to a patient, the drug by itself may be very toxic and have a lot of side effects. But if you link it to this antibody, the antibody will carry the chemotherapy directly to the site of the tumor. And at the site of the tumor, these drugs get sort of absorbed or incorporated into cancer cells, where they really get released inside of the cancer cell and mediate the killing of the cancers. And the goal of these novel technologies is, again, to essentially take more toxic drugs that we normally could not give, like these very toxic chemotherapies, and then bring it to the site of cancer. And these have shown some good success, both in cervical cancer and others. So the first example I have here is this drug called tisotumab vedotin, or it's an antibody drug conjugate targeting a protein on the surface of cancer cells known as tissue factor. So this is an example of what we call a waterfall plot, with the bars, each bar is an individual patient. If you see a bar going down, that means the cancer is shrinking. If you see a bar going up, that means the cancer is growing. So you can see a large number of patients on this clinical trial had their cancer shrink either a little bit or by actually quite a lot. In this case, you can see there are some patients that had a complete shrinkage and elimination of the cancer with these kinds of drugs. So on the basis of this, the drug tisotumab is actually now also FDA approved for therapy of recurrent cervical cancer, and this is for all cervical cancer patients. There's another drug that you may have heard about called Enhertu. So this is another type of an antibody drug conjugate targeting a molecule known as HER2. This is most commonly expressed in breast cancer, but also pretty common in cervical cancer as well. And in the patients that received this Enhertu, patients with cervical cancer that receive Enhertu, depending on how high the expression is, meaning like how high is this HER2 expressed on the surface of cancer cells, they could have a pretty good response to these drugs. So, for example, with the highest level of this molecule being expressed on the surface of cancer cells, over three-quarter of the patients have a good response to this drug. So on the basis of these very impressive findings, FDA actually approved the Enhertu for therapy of HER2 positive cervical cancers. But this approval is actually not just limited to cervical cancer. Essentially, the approval of this drug is for any cancer that expresses HER2. So this is also relevant to endometrial and ovarian cancer as well. So what do we have in terms of arising on the horizon? So there are other types of immunotherapy drugs that can be potentially promising for cervical cancer. And one that I wanted to highlight that is a fairly complicated therapy, but hopefully it will make its way into treatment of our patients as well. And this is known as adoptive cell therapies. And essentially, this is the approach where we take the cells out of the patient, or in this case, the T cells or immune cells, expand them in the laboratory, so make a large quantity of them, and then put them back into the patient with the goal of them recognizing and killing cancer cells. And this type of therapy is already approved for a number of what we call liquid malignancies, such as leukemias and lymphomas. But unfortunately, none of those therapies have been approved for solid tumors, including the cervical cancer. So there are different types of adoptive cell therapies that exist. One of the original ones that was developed is known as TIL therapy, or tumor infiltrating lymphocyte therapy. Essentially, the way that this works is the patient needs to undergo surgery to get the fresh tumor collected. The researchers in the lab then isolate the T cells from these tumors. These T cells are grown out in the culture, and then they infuse back into the patient. You can imagine that this process is pretty complicated because it requires surgery, collection of a large enough tumor specimen, and also for that tumor specimen to have enough T cells to expand to put back into the patient. So to overcome these complexities, there are a number of other kind of strategies that are being developed, and this is where the T cells can be taken directly from the patient's blood, and then these T cells get genetically modified to specifically express the receptor that would target the tumor antigen that we are trying to recognize. So they essentially, these T cells are engineered to specifically go to the tumors that express the targets for these T cells. And this is precisely the type of therapy that's approved now for various leukemias and lymphomas. And there are other approaches that are also can be in development. So can this work for cervical cancer? The answer is possibly. So this is one of the earlier trials of what we call TIL therapy for cervical cancer. Again, TIL therapy is the first one that I highlighted. So this is the more complicated approach where the patient's tumor needed to be cut out, then the tumors get processed to isolate the T cells. T cells then go through this sort of various process of culturing and then get infused back into the patient. But this study that was now reported several years ago demonstrated that a number of these patients can actually have significant tumor shrinkages. So and in this study, close to 50% of the patients had a significant shrinkage of their tumor that was quite durable. So we're hopeful that these types of strategies can also be incorporated for therapy of cervical cancer in the future. But again, these are all experimental at this point, and we don't have any drugs approved. So I'm going to stop and summarize here that to highlight that cancer immunotherapies can come in many various types. These could be immune checkpoint inhibitors, vaccines, and adoptive cell therapies. So I spent a long time talking about the immune checkpoint inhibitors such as pembrolizumab or Keytruda, and we already have approval of this drug for both early and late cervical cancer, but we certainly need to do more work to understand what's the most appropriate combination partner for this drug, like what do we combine it with, and also how to sequence it with the standard therapy such as radiation. I also highlighted some of these novel drugs known as antibody drug conjugates, such as tisotumab and HER2. And this is a novel approach to bring chemotherapy directly to the tumor, and which can also benefit a large fraction of cancer patients. And we have some early data to suggest that adoptive cell therapies can be effective against some cervical cancers, but certainly more studies are needed. So I am going to stop here, and I'll be happy to answer any questions you may have. I know this was a lot of information.